Welcome to the Birmingham Medical News Podcast. I'm Steve Spencer, the founder of the Birmingham Medical News. We are a monthly publication. We've been doing this 21 years now. We're a monthly publication for healthcare professionals throughout Alabama as well as the contiguous southern states. And we do this in partnership with Kasuf & Company. Kasuf & Company is an accounting firm here in Birmingham that's about 100 years in business now. They do all manner full accounting service. One of our connections with Kasuf is simply they've got a great healthcare department, healthcare consulting department. They also do wealth management and, like I said, just full accounting services. Anyway, our podcast today is going to be with Dr. Chris Davis. He'll be talking about nasal obstruction and what to do about it. And it's sponsored by ExcelENT. ExcelENT is a large company that is a medical device company, but they provide comprehensive nasal treatment, and they have devices for that. The one we'll be talking about today is the ViveAir, which uses radiofrequency ablation to solve the problems of nasal obstruction. So we'll get on with it from here. Okay. So our guest today is Dr. Chris Davis. He is the owner of ExcelENT here in Birmingham. He's been in practice there for over 20 years. They've got a very comprehensive ENT practice, and Dr. Davis does a lot with nasal problems, nasal obstructions, and chronic nasal problems, things like that. Anyway, I know today we're going to talk about people who have problems with nasal obstruction, hard to breathe. So to start with, how many Americans do you think suffer from this sort of thing?
Well, Steve, there's a lot of folks out there, and the estimate is around 20 million Americans suffer from nasal obstruction of some degree, okay, whether it be mild, moderate, severe. So there's a lot of folks out there that deal with this issue.
Now, I know we're going to talk about today. I know how you're doing. If I understand it right, it's a therapy for nasal obstruction, and you're using a device called the ViveAir.
Correct.
And let's start with just tell me what that device actually is.
Yeah, so ViveAir is a device that is made by ExcelENT Medical. Mm-hmm. It's been around for about 8 or 9 years, and so it's it's got a good safety record with it, FDA approved device. Mm-hmm. And essentially what it looks like a little pencil, if you will, a little bit bigger than a pencil, but it's a device that allows us to deliver radiofrequency energy, temperature controlled radiofrequency energy to various aspects of the nose that cause nasal obstruction. That can range from, and I know we'll get into a little bit more later, like the turbinates and septal swell bodies and the valve area. It allows us to essentially, I think of it as it allows you to heat up those areas under very low temperature, but allows you to remodel those areas and to give you a long-lasting result of allowing air to be moved through the nose.
So you're heating up the obstruction, is that right?
That is correct.
Okay. Okay.
One of the analogies I use for patients to kind of paint a picture in their mind is think about the way a blacksmith heats up metal, right? You can bend it, when you do that. Obviously, we're not heating it up to that degree. It's about 60 degrees Celsius. Okay. But that heat alone and delivered in a controlled fashion allows you to remodel the structures in the nose so that allow you to have better airflow.
And let me ask you this: you see a lot of patients. What sort of symptoms would be the person who would be the ideal candidate? Yeah. What would their symptoms be?
So a lot of these folks come in, they'll tell you, hey, I've suffered from nasal congestion, obstruction. Everyone has different words that they use to describe their symptoms for years. And some of them will say, hey, I have this obstruction all the time. It's 24/7. Other folks will complain about it more when they exercise. They'll notice that they have a harder time breathing through their nose when they're exercising. A lot of times it's associated with sleep problems. So when you lay down, if you already have some anatomical issues at baseline in your nose, when you lay down, you tend to get more congested. Everyone does to some extent. Yeah. And that's when it can really exacerbate their symptoms, is when they're trying to fall asleep and staying asleep at night. So it can be a number of things. It could be all day. It can be when I exercise. It can be, when I'm sleeping. But those are the types of patients that we'll see come into the office and complain about their nasal obstruction.
And what's going on anatomically when people have nasal airway obstruction?
Yeah, I mean that's the $1 million question, right?
Okay.
I mean, I think if you think about patients, they most folks come in, the nose is in the middle of their face, they look at it every day, but they don't see what's going on inside, right?
Yeah.
So one of the first things that we do when we're evaluating a patient is to gain an understanding what's going on inside, okay? Not just for me as the physician, but also I want the patient to know that as well. So, are we seeing things like a deviated nasal septum, okay? So the nasal septum is that structure that sits in the middle of the nose. It's like a wall, it separates the right side of the nasal cavity from the left side of the nasal cavity, and like a wall, you want it to be straight, right?
Okay.
So deviations means it goes from one way or the other. That can be one problem. So other things that we talk about, there are little shelves in our nose called turbinates, all right? And we have really 3 sets of them: inferior, middle, and superior. That inferior turbinate serves a very important function. It warms and humidifies air, but at the same time it can become enlarged and cause nasal obstruction. So that's perfect for Vivere to treat, right? There are also little structures, I call them mini shelves, some along our septum, are called septal swell bodies. So think of that as like a mini inferior turbinate. Those can swell up too. Another perfect target for Vivere. And then finally, the nasal valve. So the nasal valve, think of the nasal valve. Have you seen athletes wear breathe right strips before?
Oh yeah, absolutely.
Yeah. So what they're really doing with those breathe right strips are opening up the nasal valve. The nasal valve is between the lateral wall of the nose, or what we think of the ala or the nostril of the nose, and the septum. There's a little slit right there, and that actually is the highest resistance of the nasal airway. And so what they're doing with that breathe right strip, they're opening up that nasal valve. Well, what Vivere does, it targets that area and allow us to permanently remodel that area. So you essentially have a built-in breathe right strip. All right?
I've actually used breathe right strip.
They work
by the way.
great.
Yeah,
it's actually one of the ways that we test for a patient. Like I had a patient this morning. We do a test called a modified caudal test. Right. So when we put a scope in the nose, we lift up that upper lateral cartilage that makes up the sidewall of the nose, and we say, hey, does that make you breathe better or not? And in some patients, they'll say, oh man, that's a game changer. That's a positive test that tells us, yeah, you know what, you could be a very good candidate for Vivere. But sometimes patients are like, I don't know if that really made a difference or not. And so what I'll do with those patients, I'll say, hey, go home, put a breathe right strip on, wear it around the house, wear it when you sleep, wear it when you exercise, wear it when you ever have problems breathing. If that makes a difference, it really tells you you're going to be a really good candidate for Vivere. So so the breathe right strip test, we call that, can be a really good indicator whether or not someone would have success with this procedure.
And you call that the caudal?
Yeah, it's called a modified caudal test. So one of the ways that patients will sometimes, they'll come in, they'll explain, they'll say, hey, doc, when I take my fingers and I pull my cheek out, that makes me breathe better. That's actually called a caudal test.
And I think that's what y'all also call the finger pull test.
Yeah,
is that right?
Exactly,
Okay.
Yeah, and but the modified caudal test is we take it's a small little curette, and we place it with the scope, and we look at it, and we lift up that sidewall of the nose. That's why we call it modified. It's a little different because we're using a little instrument to lift that up. And that's another way of determining whether or not someone would be a good candidate for that. So so those are the kind of the ways that we can help determine the functionality of the nose and what areas of the nose are causing problems for a patient.
So when somebody qualifies and you set up the procedure, what kind of walk us through the procedure? In other words, how long does it take? Well, how does it feel to the patient before, during and afterwards? And also, what's the rest of their day going to be like?
Sure. So I think the first thing is, and kind of going back to the last topic we were discussing, is making sure patients understand what's going on in their nose. Like I said, it's in the middle of our face. We look at it every day, but we really don't look at what's going on inside. And we don't realize all the little areas that can go wrong. So I think the first part is to educate patients on their options. We call it shared decision making. In other words, my job as a physician is to make sure you understand what's going on in your nose that's causing your problems. Right? And then from there, we can have an intelligent discussion about how you want to proceed in managing with that. So if surgery is something that you would like to talk about, that could range from, doing something in the operating room, dealing with your septum, and also doing the Vivera procedure, okay?
Well, you might do both of those
You
together?
could do those at the same time,
okay,
yes, sir.
okay.
That's what I call comprehensive nasal airway surgery.
Okay.
Where you're dealing with the septum, you're dealing with the turbinates, you're dealing with the valve, you're dealing with the swell body, all these anatomy issues that someone can have. I've had many patients come in my office and say, hey, Chris, I don't want to go to the operating room. Okay. It's the downtime that's required. There's no doubt that it's going to require downtime. The cost, the expense, of going to the operating room. You're going to be paying for an anesthesiologist. You're going to be paying for a facility fee, and then obviously the professional fee from my part. And so there can be a cost factor. And so all of those things, combined, will sometimes make a patient decide, well, maybe I don't want to go to the OR. Can we do some things in the office that are going to cause or decrease my symptoms? And so that's the great thing about this device. You can do it in the OR, you can do it in the office, and as long as a patient understands what they're getting into to each of those routes, and there are certain things that I can't treat in the office, like severe septal deviations. Those are things I have to do in the OR. But I've had patients come and say, I understand I have a septal deviation, but I think we should try this Vivera route first before we go to the operating room. That's not a wrong decision.
Yeah.
Okay? And so our job as a physician is to make sure we're shepherding those patients through that decision-making tree, if you will, and making choices that are best for them. So now to answer your question about, let's talk the office experience, right? So typically what I do, office procedures, I usually do them on Friday mornings, all right?
Okay.
I don't want a lot of stuff going on in the office, seeing a bunch of patients. I'm usually going to be having a much slower schedule, and I really want to be focused on the patients that I'm doing these in-office procedures on, like Vivera, okay?
And maybe it even is helpful for them if the weekend's coming.
Yeah, the weekend's coming. It's great, and they can, by Monday they're back at it, what they want to do.
Okay.
And so usually what to me, setting up the patient is educating them on the front end, right? So giving them expectations. So I tell them, hey, you're going to come in on Friday morning. I don't usually give any type of medications that are going to make them drowsy because they really don't need it. Okay. I don't give them Valium or Ativan or anything like that. The first step is numbing up the nose.
Okay.
And we do that. And I actually tell them that numbing up the nose is going to take longer than the actual procedure itself, right?
Okay.
But if you set the table for that, it's going to make a very pleasant experience for both the patient and the surgeon as well. So we begin that, we do some topical numbing, and we spray some tetracaine in the nose with some Afrin to decongest the nose. We let that sit for about 5 minutes, and then we take that same concoction, if you will, and we put it on like compressed cotton balls, all right? And we place that in the nose, okay? And then after we do that, we let that sit for about 10 minutes. We remove those. And then the patient's pretty numb at this point, but I want them really numb. I want them to, they say, hey, I don't even feel my teeth. That's perfect. And then we inject some areas with some lidocaine, just like they do at the dentist office, right? If you're having a filling or, a root canal or whatever. And then we put those same pledgets in with that numbing medication in again. So that's another 10 minutes, right? So you're talking about 20 to 25 minutes of numbing up a patient. And now when you walk in the room, you take those last pledgets out, and you're ready to begin your procedure. I mean, that patient's usually like, I don't even feel my face, all right?
Now, I'm going to have kind of a ignorant question probably. Yeah. At that point, because there's a lot of, as you mentioned, a lot of parts to the inside of the nose. Yeah. Before you start the procedure, do you know where the obstruction is?
100%. So that goes in the initial evaluation.
Okay.
Right? So I generally don't do the procedure the same day the patient's coming in because I got to learn about their nose and they need to learn about it too.
Okay.
They also need to be educated on their options, and a lot of people want to think about it. And I want them to think about it. It kind of makes me nervous when people are just like, hey, let's go do this thing right now. And usually I'm not set up to do that because I have a busy clinic, and so that's why I like to allocate this time for these patients. So the initial visit is when I'm going to get to know about your nose, and when you're going to get to know about your nose. That's when we're going to do what we call a nasal endoscopy. We're going to look in your nose. It's real easy. We do it in the office. And I take pictures and videos of that. Sometimes we'll get a CAT scan of the sinuses too, if we want to look further back into areas. and then taking those two pieces of information, what I call objective data, what your scope findings are, what your CT findings are, then combining that with your symptoms that you have, you know, and saying, okay, here are the areas that I think we can target, and this is how we go about doing that. And then you inform the patient of those there, and then you let the patient make a decision for themselves.
Okay.
And so, since we're talking about, you know, the in-office, that patient is probably said to me, "Hey, Chris, I really don't want to go to the operating room. I don't have time to do that, but I want to feel better, you know, sooner rather than later." And then we talk about doing an in-office case, and so I would bring that patient back on a Friday, like we were talking about.
And they've been through now all the numbing.
Yes,
right.
Yeah, and now we're ready to start that procedure, and they've been through that numbing, so or that the anesthetic protocol, and so like I said, the procedure itself takes probably somewhere between 7 to 10 minutes. Okay. And we're going to target those areas that are appropriately causing the nasal obstruction. So like the nasal valve area, the turbinate area, and the swell body area. Those are anatomical structures that are very easily treated with TCRF, and TCRF stands for temperature controlled radiofrequency ablation. And essentially what you're doing with that is you're delivering low levels of energy under a controlled fashion and remodeling that tissue to open up the airway.
Okay.
So what you're not doing with that procedure is you're not straightening the septum. Okay, you see what I'm saying? That requires potentially going to the operating room to do that. But you can certainly hit 3 of the 4 of those targeted areas very nicely in your office. Again, you know, patients sometimes don't want to deal with their septum, right? You know, they're like, hey, I just don't want to have that. I've had friends that have that procedure, and it just seems a lot. I don't want to deal with that. And as long as the patient understands that that could be still a factor causing their nasal obstruction, but they're willing to say, let's try this first, that is not an unreasonable option. You have other patients that'll be like, hey man, let's just go for it and let's knock everything out. And if that were the case, we could do this exact same procedure that I just described it to you in the office. We can do it in the operating room and also address their septal deviations if need be.
And one quick question too. So you mentioned there's 3 or 4 areas that probably you're going to target. And I assume sometimes you need to just target one. I'm just assuming sometimes it's 3, whatever.
Yeah.
But my question is, and maybe percentage-wise, what percentage maybe of patients have the septum problem too, and they may not choose to do both, but they probably could. And what percentage don't actually need that, or just fine with just the
in-office procedure itself? I think, you know, Steve, it's about a 50-50 mix.
Okay.
You know, it really is. You know, it really is. I give an example of a patient. This was a year or so ago. I mean, he was a pretty big fella. You know, he was very athletic. I think he was in even bodybuilding and things of that nature. And he just like, look, I'm in competition right now. I know I have a deviated septum. Okay, he goes, I've seen 3 other guys, and they all said septoplasty to him. And he goes, and if you say that to me, I'm going to walk out of the office. And you know, this is a pretty big guy, so I wasn't going to make him mad, right? You know, and so I said, well, hang on, let's just take a look, and we did, and we scoped him, and I showed him. I said, well, I understand why they said septoplasty. You've got a bad deviated septum. You know, I mean, that's not an unreasonable option, but you also have valve collapse. You also have turbinate hypertrophy. You also have swell body formations.
So that's a lot.
He had a lot. Yeah. And he said, well, he goes, Chris, I know you do this procedure. I've heard about you, and you do this procedure. You know, I don't want to do the septoplasty. I want to target those 3 things. And I said, that's fine. But you know what? We had an understanding. He understood that, yes, the septum could be causing him some problems. And he got that. But he also knew he had these 3 other problems too. And because of his schedule, it was not an unreasonable option to say, let's hit 3 of the 4 of these things and see how we do. So that's what we did. Fast forward 6 months later, 8 months later, I see him in follow-up. He's like, man, I'm breathing great. It's the best I've ever breathed my entire life. You know, I can use my CPAP now at night. You know, that's another thing. He start breathing through his nose so he can use his nasal CPAP. Yeah. And he says, I do feel a little bit more of a hindrance in my breathing on one side. It was the side of his septal deviation one. He goes, but I am so much better. And he's like, I don't want to have the septum done. He goes, but if I ever decide to do it, you'll be the guy that does it. Okay. But this is a guy that, again, we had an understanding. He understood his pathologies. That's my job, to make sure that they understand that. Again, shepherding supporting him through that process. And then he can make a reasonable, intelligent decision, which he chose to do in an in-office case. Right, great, and he's doing great. And so I don't know, he may never need a septum done.
Yeah, that's interesting. So it sounds like it varies a lot.
It does vary a lot.
Yeah.
And again, people's motivations and their tolerance for things of like operating room versus non-operating room versus what's their life like at this day in their in time. Also, medical comorbidities. There are a lot of patients that you don't want to take to the operating room. I've had that before too, and so all those things. That's what's so great about this technology. You can really do it at any site of service you want to. You can do it in the operating room, either in the hospital or ASC or ambulatory surgery center, or you can do it in the office.
Yeah, and what's interesting to me too, it sounds like, I'm sure people vary so much. There may be some people who you do the Vivair, if I'm saying it right, and they also have a deviated septum, and it doesn't make a big difference. In others, it makes a big difference.
That's correct.
They can, I would assume. Well, let me ask you this: so the folks who do just the in-office, what improvements do they notice, and like how soon do these things show
that's
up?
a good question. Again, I think that's part of the patient education process. So the first thing I'll tell them that, hey, no matter what, even though this minimally invasive procedure that we're doing, it's still a procedure, all right? And your body develops inflammatory responses when you manipulate it, all right? So I tell them for at least probably anywhere from 3 to 7 days after the procedure, you're going to feel more congested than when you walked in here, right? It just makes sense. If we're gonna manipulate tissue and we're gonna remodel it, that tissue is gonna have a response to it, right? And so initially you're gonna have a pretty robust response in the nose, and you're gonna get more congested. So don't be alarmed by that.
Almost when you get a vaccine.
Exactly. It's like when your arm swells up a little bit, right?
You're getting that inflammatory response.
Exactly right. Yeah. So I tell them for those first 3 to 7 days after the procedure, you're going to have that. The other thing I tell them that you're going to note, especially in the front of the nose, a little bit of crusting where we treated the valve. Okay, as air is brought in through the nose, the nose is an amazing organ. It really is. It it does so many things. One of the things it does is it warms and it humidifies air, right? And so when you manipulate the nose, some type of procedure, that creates an inflammatory response, and when it does, you're going to develop crusting in that area, right? So in the very front of the nose, as air is getting drawn in, it's not getting warmed yet. It's not been humidified, so you'll get a little bit more crusting in those front spots.
Okay.
And that's easily mitigated with like some saline sprays or some using some Vaseline or mupirocin ointment. And I tell folks to apply that to that area for about 2 weeks. And then what happens is that area just sloughs off, right? And then the swelling goes down. And as that swelling goes down, that's when the tissue starts to remodel itself, right? So, you get that curvature of that upper lateral cartilage to widen that nasal valve area. And so I tell folks probably around somewhere between 4 to 6 weeks, you should be about, 85 to 90% there.
Now, in those initial post-surgery days, do you, with the inflammation, do you tell people to use ice or any?
I tell them to rinse their nose with a little saline rinse. That helps a lot.
Okay.
Yeah, it really does. It helps wash that crusting off and keeps it moist and things of that nature. You won't have any swelling on the outside of your nose. You really won't. Your nose, and that's an important concept too, is your nose is not going to look any different on the outside. Okay.
Yeah.
It will look different on the inside, which is what we want. But this is not a cosmetic procedure. And it can be combined with cosmetic procedures because, like I said, it can be really combined with anything. But it's not going to make the nose look different on the outside, but it will make it look different on the inside. And that's what we want to improve nasal airflow.
Yeah, right. And how durable do the results appear to be?
That's great. One of the great things that Aaron has done in their rolling this product out is their clinical studies have been phenomenal. Most surgical studies, if you look at like how long they follow patients out, it's usually for like 6 months to a year or whatever. I mean, Aaron's got studies that are as far out as 4 years, which is pretty remarkable for following surgical device studies. And 4 years out, I mean, you're still seeing high responder rates. I mean, up in the 80-90% range. So that tells us that this has got durability. And I can tell you right now, I can think of only maybe a couple of patients that I've had to repeat the Vivair, on, and that's, again, I've done a lot. I've probably done, I don't know, probably 500 or plus of these cases, so a lot. Yeah, we're getting up there. Yeah, yeah.
That's interesting. And what's the availability in Birmingham, and how does insurance handle it?
Yeah. So that's a good question. I think there are a lot of surgeons out there that do this procedure. I'm not going to say I'm certainly not the only one. There are lots of them out there, I think. So that's one thing, is that there are guys out there that are doing it. And that's great. And as far as the insurance stuff, most Medicare and Medicare products, will cover this. All right. The commercial insurances are a little bit, iffy on that. And so if you think about Vivere, we can treat, 3 anatomical sites. 2 of those 3 are going to be covered by insurance.
Okay.
One of those sites, one of those 3 are not going to be covered by insurance.
Okay.
And so we have an open discussion with patients about that. That's another thing that people will kind of use in their calculus as far as what they want to do and how they want to do that.
They may just choose the 2 sites that are covered.
Yeah, they may choose the 2 sites, or maybe do the septum or whatever. Again, it's all about being open with patients and discussing that.
Yeah.
At the end of the day, my job, I always tell folks, my job is to keep the person in front of me happy and also give them as many options that they can choose from that are reasonable. And so I don't let insurance get in the way of me making those offerings to patients. In other words, if I look at it and say, oh, this patient has X insurance, they don't cover that procedure. I tell them that. I tell them that in the consultation. Hey, look, unfortunately, your insurance doesn't cover this procedure, but you can still do it. We can still do it. It will just be a cash price, and they understand that. And there's transparency there. And if a patient says, hey, I don't want to do that, then I'm not making the decision for them. They can make that for themselves. But most patients, will be like, okay, that's a reasonable option, and if they want to pursue it, then that's available to them.
Yeah, essentially, it sounds like you're really big on educating them.
It's huge.
Because you're educating folks not only on what their problem is and what you're going to do and how it's going to feel, but also what it potentially may or may not cost.
Yeah, I mean, that's exactly right. I mean, education is paramount and for patient decision making. I mean, it also makes my job easier.
Yeah, because if the patient understands everything, they know what to expect, and more importantly, it's just better for them to know as much as they can and then make a decision.
Exactly right. I spent a lot of time, you mentioned that front end, I spent a lot of time at that initial consultation with patients, going over their anatomy and making sure they understand all those things.
Yeah.
And almost to a point where my medical assistants will knock on the door and say, hey, come on, you can keep going here. But, I really want them to be properly educated on what's going on in the nose. So then they can make an educated decision for themselves.
And I wonder, during that consult, is there anything that you'd recommend patients to ask?
Oh,
it sounds like you're covering everything they could ask, but are there things that you recommend nonetheless?
Yeah, one of the things I think, a lot of times patients, before we even get to the concept of surgical manipulation of the nose, I tell folks, think about the nose. There's 2 things that go wrong, and this is oversimplification. There's anatomical problems and there's inflammatory problems.
Okay.
All right, and either one of those things can constrict the airway. Okay, so if you've got anatomy problems, that can make the pipe more narrow, right? If you've got inflammatory problems, that makes the pipe more narrow. And honestly, most people have both. Most people have a little combination of both. So, before we even start talking about surgery, I always medically manage the nose. What does that mean? Okay, well, that can mean a whole bunch of things. Most people, by the time they get to my office, have tried various nasal sprays. Nasonex, Flonase, Nasacort, you name it, they've tried it. We tend to be a little bit more aggressive with our medical management, and we will usually put them on what we call mometasone elastine nasal irrigation. That's a mouthful there, I know. But mometasone is essentially Nasonex. It's the same compound. And nasalastine is Astepro. That's an antihistamine. And we'll have them rinse with that. We know that rinses are able to deliver medications much further into the nasal cavity than a spray. So before we ever have that conversation about, hey, let's go do something to your nose, I'm going to put a patient on that for probably about 8 weeks. And see them back. And a lot of those patients, honestly, Steve, I see a lot of these patients like, hey, man, this is the best thing I've ever, this is the best thing since sliced bread, this rinses, that's fantastic. And, do those patients need surgery? No, they don't. But those patients love love you. They're like, hey, this is fantastic. I'm doing good. And I'm like, awesome. I'll see you back in 6 months. And hopefully, you just keep your rinses rolling.
Now, are they able, so there's you can use a rinse like that
100%.
in perpetuity?
Yes,
okay.
100%.
Okay, that's good.
But then you have others where that doesn't give them the relief that they want. And I tell them, well, it's not that the rinse didn't work. It's that the pipes are too clogged up to get the rinse back there, right?
And it may mean there's something anatomical, because if I understand you right, the rinse is for inflammation, right?
That's exactly right.
Right.
And that's when these procedures kind of come into play, right? The turbinates are too enlarged, the swell body's too enlarged, the septum is too deviated, the valve is too collapsed, so therefore things can't get back into the nasal cavity to drive down that inflammation.
And by the way, I'm backing up on what we already just said, but I'm sure patients really appreciate it when you just let them try the rinse and
100%. Yeah.
I would.
And again, I think one of the things that you get out of that too is that patients are realizing that you're not just trying to rush someone to the operating room or to the office to do a procedure. You're being diligent about that. I want to know what they've done. A lot of times patients will come in and say, like, I don't know, I don't know what I would do to my nose. I don't do anything to my nose. Like, well, hang on, let's back it up here before we start going into surgeries and all this kind of stuff. Let's make sure we're dotting I's and crossing T's from a medical standpoint before we start offering these procedures.
Because regardless of whatever the service is, medical or otherwise, we always appreciate it when somebody shows us something that we know they're not just trying to make money.
Correct. That's exactly right. And again, that's the best thing for the patient. I see patients all the time. I would say probably about 50 to 60% of my patients, we never do a procedure.
Wow. Okay.
The others are the ones that we do.
Yeah.
Because they have failed medical management strategies.
And that builds, not only do people appreciate it, it builds trust too.
Yeah, absolutely.
Yeah.
Absolutely.
Well, let me ask you this now. All right. So we're going to have people probably watching this who have breathing troubles, and obviously they don't. Who knows if it's inflammation or anatomical?
Right.
But where should they go to learn more about it?
Well,
their problems.
I'm going to toot our specialty's horn a little bit.
Okay.
No one knows the nose like an ENT knows the nose, right? ENTs are well trained to from a surgical perspective and from a medical perspective of looking at the anatomy and knowing what is wrong. Okay, so I would certainly tell you if you've tried the conservative measures like Flonase and Nasonex and over the counter like Allegra and Xyzal and all these things that you can go to your pharmacy and look in the back. The largest section is the allergy and sinus section, right? And I always go back there every so often just to see what's new back there. When my patients tell me I tried this or I tried that. There's a lot of over-the-counter stuff. But when patients are not having success with that, and then that's when they really need to kind of reach out to an otolaryngologist. That's the specific name, but an ear, nose, and throat surgeon, and start to get evaluated. To start that process doesn't mean that you're going to need surgery, but it means that you need more than just the over-the-counter stuff, right? And then that's where the process can be initiated from.
Okay, well that's great. Is there anything I didn't ask that we need to bring up?
Well, I think the main thing is, I think we covered, pretty much everything, but it's just to realize that you don't have to live this way, right? 20 million Americans are out there suffering with chronic nasal congestion. And so there's a lot of options out there now for you. In the old days, it used to just be everybody got a septoplasty and a turbinate reduction. That's the way it always was. But there are a lot of options out there that can give you relief without having to necessarily go to that full court press of doing those operative procedures. And so I would encourage you, if you're having those problems, to pick up your phone and go to your nearest ENT and see what's going on in the nose, so that you can get some intelligent education on what is going on in the nose and what your options are.
Okay, well, sounds great. Well, thanks a lot for your time. It was some great information.
Yeah, thanks, Steve. I appreciate
Absolutely.
it. All right.
Yeah. Thank you for listening to today's episode of the Ask the Doctor podcast, brought to you by the Birmingham Medical News and Kassouf & Company. Please make sure to like and subscribe, and make sure to tune in for our next installment. I'm Steve Spencer, and wish you and your loved ones a healthy journey until we see each other again.